Today, we have Dr. Edward Linn. He's a trustee of the Chicago Medical Society and a co-chair of the COVID-19 task force. He's currently a member of the Village of Skokie Board of Health. He's a professor emeritus and former interim chair of the Department of Obstetrics and Gynecology at Rush University Medical Center and Rush Medical College. Previously, Dr. Linn served as both the chairperson of the Department of Obstetrics and Gynecology for Cook County Health and an associate professor of obstetrics and gynecology at Northwestern University, Feinberg School of Medicine. During that time, Dr. Linn was responsible for directing and coordinating the provision of obstetrical and gynecological services through the facilities of the Cook County Health Service. There's a whole bunch of stuff I can talk about him, but I don't want to take away from his presentation. Now, he could have talked about all sorts of stuff in medicine, but he decided that it was important to take the subject of understanding and analyzing scientific data so that he can make it understandable for our audience. So with that, if you don't mind my not going further with your resume, I'd like to introduce to you Dr. Edward Linn, doctor. Anyway, here you go, Ed. Now I'm going to turn this one off. I think your mic is going to...
Are you able to hear me with this
yeah.
microphone? Okay, good.
Okay.
I was having a flashback to earlier in my career when I was giving a talk up here on the North Shore to the group that was responsible for raising funds for Brandeis University. They used to have a book fair. And there was an organization that supported it. And apparently my hospital had arranged for that. At that time, I was at Michael Reese Hospital of blessed memory. And they sent a copy of my CV, which is, for those of you who don't know what a curriculum vitae, it's like a resume. And the host who was welcoming me to this talk, she said to me, I'm a little overwhelmed. And believe me, the CV was small at that time. There wasn't a lot of heft in it. How should I introduce you? What are your most important accomplishments? And I said, I'm married and have 2 daughters. That's my most important accomplishment. So that's how she introduced me. And so I was telling my wife at the dinner table and my oldest daughter at the time, who must have been about 6 years old, she said, you mean the most important things you've ever done in your life are the 2 times you had sex? So I was thinking maybe I should use that for my introduction. What I hope to accomplish this morning is to try to give you a way of understanding what is often being presented in the media incorrectly, or presented in such a way that you don't really understand the jargon that's being used. Now, I have to say that a lot of this is going to be basic statistics, and I hope I'm not going to bore you to death. And my foray into statistics started in my freshman year of medical school. And I, you know the old expression that education is wasted on the youth. I could have been the poster child for that, because when I was realizing later in my life that maybe I should have paid more attention. My professor was kind of a strange guy. And the way he would teach the course, he would take what was considered to be the most important scientific article. Like, I remember one time he was talking about, the best treatment for breast cancer. And this is in the 1970s. And he then proceeded in the course of the week to shred the article and explain to us why the conclusions that the author thought they proved were in fact incorrect. Now, this man's name was Paul Meyer, and I know I have at least one physician. Any other physicians in the audience? Okay. Oh, there you are. Sorry. So he was world famous, and I didn't really appreciate that because as later on we used to use Kaplan-Meier curves, and he was the Meyer who helped develop these, and it's all over the world. You see it quoted all the time. And then later on, when we were getting into an era of what we call evidence-based medicine, so they wanted doctors now to start using scientific evidence as justification for their treatments or for their management of patients. And I'm going to point out what evidence means. And in order to fully understand it, you have to be able to understand the concept of causality or causation. Does something that you're doing cause a benefit, or does it lead to a problem? Does this medication treat the problem or not? And I'm going to show you why we have a little bit of challenge, dealing with humans. And but there was some criteria that were developed by a British statistician, and his last name is Bradford Hill. And Sir Austin Bradford Hill. And we ended up having the Bradford Hill criteria, and I'll show them to you in a moment. So this is probably in the late 90s or even early 2000s. I'm writing this lecture on the Bradford Hill criteria. And just coincidentally, I was being asked by my wife to get rid of some of my old textbooks, or at least find a better location for them because they were cluttering up the decor. And I all of a sudden pulled out this textbook and I go, oh my gosh, this was my statistics textbook from medical school in 1971. I took this course, and it's written by Dr. Bradford Hill. Shows you how many times I looked at it. I didn't even know who this author was, and this was the book we were supposed to be reading. It took me 20 years to appreciate what he's doing. So today I'm going to try to take you on a little bit of a trip with me. So this is an example of scientific reasoning and I'm using the example of residents. So in my career, I've taught a lot of residents. And we're having an evidence-based case management conference. And there are a number of different management options were offered. One resident, Dr. X, supported her opinion with a supportive review of an article in Contemporary OBGYN. That's what we call it's not really a scientific publication because the articles submitted are not reviewed by an editorial board. But this is more of a place where reviews or summary articles would be put. And then Dr. Y felt that the study published in the New England Journal of Medicine was more credible because they use editorial boards to review the articles before they're published. And the professor who was in the room overhearing the debate offered his management opinion, supported by years of experience. So just park this in your mind. We'll come back to this in a moment as to which of these would necessarily be the best level of evidence. So we have a jargon here, and this jargon I hear on the news. I read in the newspaper. So one of the things we have is this term risk. Has anyone ever seen when they talk about risks, when they report a scientific study? Risk is kind of a strange word because risk could also mean something good. Most of us think of risk as being a pejorative term. Another way of thinking about risk is a more common way is maybe the term probability. So in other words, if you give this medication, what is the probability that the patient will get better because of the medication and not just because of time? And so we came up with these terms, relative risk, and I'm also going to tell you, I think there's a better term, and it's called attributable risk. Another term that you may have heard is significance. They'll say, oh, this article was statistically significant. So again, a lot of people think, well, if it's significant, it must be important. And if it's important, it must be correct. And so this is a way of supporting your evidence. Now, another term that we hear often, or you may read about, are what we call odds ratios. And that's just like going to the track or playing the stock market. You know, what is the probability of something being correct? What are the odds? But two of the most important things that are never, ever covered well are bias, because when you look at studies, there may be built-in biases. And I'm going to point these out to you. It's a lot different than what you may think it is in a social context. And a term called confounding. Okay, this is kind of the introduction to the language. This all comes out of epidemiology, which is basically the study of the distribution of diseases in population. But a lot of these epidemiologic techniques have been applied, to whether or not we are exposed to diseases and what the risks are, and what is the probability of a disease getting improved by a treatment. Now, epidemiologic studies are to estimate the relation between exposure and the outcome in order to establish whether causal relationship exists. It should be relationship. So there's two ways that studies are being done. One is the experimental. Now, the experimental is considered to be the holy grail of scientific evidence. And the way I think of experimental is what we do in the laboratory, where you have total control of things. And we now have a new thing called translational research. You may hear about this. It's where how you take what's being done with an animal or with a microbe in a laboratory, and how does it translate to applying to humans? It's a big challenge, and it doesn't always work very well. Because, for instance, when you're doing an animal experiment, you can have total control of genetics. You can have a mouse clone that every single living organism that's being studied have the same genetic components. They all came from the same parents. They just keep on extending the breeding. And so the investigator can control all the factors. That's hard to do in humans. We try to do experimental studies in humans, and I'll point that out, but really we don't have that capability. People, excuse me, let's see if I can kill this. Now, so what we do with most human experiments is we call observational. And that's where the investigator does not control the exposure. And these are maybe population studies. About 85% of what we do in medicine is based on observational studies. And you need the Bradford-Hill criteria with observational studies because it's a lot more complex. So remember, the laboratory experiment may be done leading up to it, but ultimately when we're testing human beings, we can't put them in cages. We can't feed them the same food. We can't give them the same total environment. So we try to control these by using statistics to try to determine whether or not this is working. And this is an example of the classic experimental study, where you may have, again, we'll use mice, and you randomize them into two groups, and you expose one, and you look at the outcomes. And you can do over time, as an example. And you can compare the exposed group to the unexposed group and look for the differences. In other words, does the exposed group get better? Or if you're exposing them to a disease, does the exposed group get worse? Observational studies are a little bit different. You have an exposure. A good example would be what's going on with COVID. You know, this is how they tested the vaccines. So you have people that are exposed, and then you look at the number who become sick. That'll be the outcome. And there's two ways of doing this. Again, more jargon here. The cohort study design or the case control study. And I don't think it's that important for you to understand that. But certainly the people who are talking to you on television should be able to understand this and explain it to you, or people who are reporting in magazines or newspapers. And you're looking over time trying to determine who's sick and who's well. So this brings us back to this mathematical formula that is relative risks. Okay. So very simply put, the relative risk is a mathematical formula. You take the number of people who get sick in the vaccinated group, and then you take the number of people who get sick who are unvaccinated, you count them up, and then you make a ratio, okay? And in case-controlled studies, we call this an odds ratio. In cohort studies, we'll call this the relative risk. It's a percentile. A relative risk or an odds ratio, and for our discussion, we'll just use them as the same. If it's less than 1, so if there's more people get sick in the group that wasn't vaccinated than the group that was vaccinated, that number will be less than 1 in terms of the ratio. That would indicate protection. And if it's greater than 1, it would indicate increased risk. So if we don't see that with the vaccines, but you can with other types of therapies. And if the number gets so close to 1, it'll indicate no association. But these are estimates. And again, these numbers vary. So if you have, like with the COVID vaccine, there were 40,000 people tested with the Pfizer vaccine and 40,000 people tested with the Moderna vaccine across the world. Those are big numbers, okay? But over time, now we have hundreds of thousands and million people. So this mathematics changes based on the size of the sample. And the bigger the sample in general, the more accurate. But you end up still with an estimate. So the statisticians use confidence intervals. When I was like in high school, we called these error bars. So the narrower the interval, the tighter the numbers, show you more precise this point estimate, this estimate. But most importantly, if they overlap 1, that means it's not statistically significant. So let me try to show you how this looks. So as I said, 1 would be the point we're looking at, because that means you have equal numbers in both groups. So 2 numbers that are the same equals 1. And as I said before, if your point estimate is below the line, so here's our line, then this suggests that there's protection here if we're looking at the case of a vaccine. But if you look at the confidence interval, you see that it goes above 1, which means that this is not significant, meaning this estimate is too vague to be considered to be protective. This particular one, because the confidence interval goes below 1, these numbers, and this is all a statistical calculation. This would be reduced risk, and this would be significant in that it's below 1. Again, non-significant, above the line, and significant means increased risk. Does everyone understand that? Because this is really very, very important, but it's frequently not talked about. I'll give you examples momentarily. Now, what I try to do here is take the old classic bell-shaped curve. If you could rotate it 90 degrees. Remember the old bell-shaped curve? Often they were used to, give your grades. Were sometimes we refer to as the normal distribution curve. Basically, this is the same thing we're talking about. So this would be the median, and we get away. And this all involves statistics, and we call these standard deviations the farther away you get from this point estimate. And what we like to know is this estimate, how tight is it? And we come up with this term of the 95% confidence interval. And that's another mathematical manipulation. Now, when we do experiments, most physicians and a lot of scientists, we make sure we work with statisticians, people who are experts in this, and they'll help guide us in terms of designing the experiment. Because if you design your experiment incorrectly in the beginning, you're going to get bad results. And there's been many, many studies like that. The biggest problem is misinterpretation. And some investigators think they've proven something. And that's why you may see 2 articles in the same journal, and the reporter picks article 1, doesn't go to article 2, and reports that, taking panaceamycin is going to cure us of, let's say, COVID. Didn't read the next article that said panaceamycin does nothing. As a matter of fact, the 3rd article said panaceamycin is dangerous. And a lot of it has to do with how the experiments were designed. A much better way, in my opinion, is looking at attributable risk or absolute risk. And that's, I think, easier to understand, but I rarely see this being done. So I'm using the example here of a venous thromboembolism, a blood clot, an embolus goes to the lung. And in my field, we dealt with this all the time because of certain hormones that we would use in our therapies. So if the rate of venous thromboembolism in oral contraceptive users is 16 per 100,000 people, so 16 people out of 100,000 will have this complication. I think that's more meaningful because, an example, I don't really care how good the odds are. And I'll give you another example of winning the lottery. So they'll tell you your probability of winning the lottery may be 1 out of 10 million. So I would buy 1 ticket. Someone else I know buys 10 tickets. Have they changed their probability of winning that grade from 1 out of a million, 10 million rather, 100 million, to 10 out of 100 million? Not really. But people don't understand this. And this is the same thing we're seeing with the COVID vaccine. They may report that people who received the Johnson & Johnson vaccine, who were between the ages of 18 and 36, had a risk of a very rare blood clot in the brain. All right. Well, that's how they get reported. I can tell you, I was staffing clinics, and you couldn't give away a Johnson & Johnson vaccine. People will come in who are 85 and because they didn't bother to look at the age distribution, and they didn't talk about the fact that this complication was so rare. It was 1 or 2 out of 1 million people, but they reported it as being a complication. And as we had more time, we're realizing that these complications get rarer and rarer the more people that have been vaccinated. So what you can do is you can take the absolute risk of the blood clot occurring in users and non-users, subtract the difference, and this gives you the attributable risk. And I think this is an easier way to understand, complications, or even you can reverse it and say, what is the rate of pregnancy prevention? A positive thing in terms of this medication. I mentioned bias before, so let me talk to you what I'm talking about here. One, we may have selection bias. In other words, the way you choose the people to include in your groups. You may have gone into your database at your hospital. We do that a lot now because we have these electronic medical records, and many institutions have set up even data mining techniques where you actually can go and pull things out. But there's a bias there because, number one, these people are being referred, and there may be something unique about people who get referred. Like maybe they have health insurance, so therefore they're being seen by this Tony private hospital where they're doing this study. And that could bias things. We may also have what we call detection bias, and we've seen this all the time. For instance, in an example, does hormone therapy cause cancer? Let's say breast cancer in women. And one of the big biases is that you're seeing maybe a group of women that are all having mammograms. So if that's your group, that's a group that maybe you're finding more cancers because they're being studied more carefully. And you need an equal number of people that aren't getting mammograms to really kind of control for that. One of the worst problems is information recall. So a lot of studies, they'll go to a group of people and say, let's say diet studies, where they're trying to make a relationship between eating a certain type of diet and a certain type of outcome, either good or bad. And they rely on the people to recall what they eat. Do you eat? They give them a questionnaire. And there's ways of trying to control for this, but it's very difficult. Attrition of the susceptible bias, one of the things we talk about there is the healthy user effect. Like there's a very famous database that is called the Harvard Nurses Study. So developed at Harvard University, it's called the Nurses Study, and it's being used for a lot of things. Diet, smoking, but in general, this is a population of people that are well connected to the healthcare system. And so they may actually be a lot healthier because they're having their problems recognized. So the consequences of anything occurring adverse to them may be less than a similar group in age, gender, who are not getting healthcare. And maybe they have untreated blood pressure, so they have a higher incidence of stroke. It may not be the medication they're receiving for their birth control that's causing them to have problems. It may be the fact that they have, a genetic predisposition, and they're not being treated early enough. Now, confounding is another big problem. And when you design your experiment, you have to look at sources of confounding. And these are some of the common ones. Gender. And I can tell you this was a big, big problem with the COVID vaccination. Okay? In that they didn't choose enough women who were pregnant. So we couldn't give good hard evidence that it was safe to give the vaccine in pregnancy, and it's created a big problem to this day. Age. In the COVID studies, they try to do a lot to control for age, but they couldn't test children. That's why originally children weren't included, because they felt it wasn't safe to expose young kids until they knew more about the vaccine. But it does change our ability to interpret things. So in general, what you try to do with confounding is you try to take care of this through randomization. And you make sure that when you randomize, that you do a scientific analysis, you determine that there's equal number of smokers in both sides, exposure or unexposed. You try to look at the similar age distribution. You try to look at a similar reproductive history. And then if you have those balanced, that lends credence to the fact that you have a really good sample. And so we use randomization for that. But again, it improves if you have a large enough sample of people. If you're just taking 10 people, it's going to be hard to do. You take a few thousand people, it becomes easier. So let's go back to levels of evidence. It goes back to my first question. The highest level of evidence would be one properly controlled randomized trial. So that's usually the one that's done under strict laboratory conditions where everything is well controlled. Okay. The next level of evidence, we call this 2, is the controlled trials without randomization. Okay. So if I'm comparing 2 papers, the one that's done with randomization, and especially if it's blinded, where the investigator, the patient, doesn't know what medication they're receiving. They're given an envelope, and it may be the active drug or maybe the placebo, and no one knows. All that's kept very secret in the pharmacy. So that would be the level 1. In 2, we have the controlled trial without randomization. We have cohort and case control studies. Remember, this is the observational studies. This is the bulk of what we do, is level 2 evidence. Okay? But more importantly is number 3, evidence derived from report of an expert committee, which itself use a scientific approach. And often that's all we have to rely on. The CDC, their expert said, this is good treatment. It's still a low level of evidence. You hope that this group has used a lot of level 1 and level 2 evidence to come up to their conclusions. But it becomes somewhat problematic. And that's why you often see the committees changing their opinion over time. And they'll tell you that up front. Based on what we know today, this is what our conclusion is. But it may change over time. What isn't evidence are opinions of respected authorities. This is not scientific evidence. So in that room with those residents, that professor, that's not considered evidence just because he says, well, in my experience, in case after case after case, this treatment works. That's 3 cases. That's not the same when you're looking at scientific studies where they've enrolled 10,000 cases. So, but that's sometimes a big problem. It's someone with the most experience, the revered expert opinion is viewed as being scientific evidence. It isn't. In the absence of scientific evidence, one might rely on expert opinion to form a clinical judgment concerning a patient's treatment. So my chairman who raised me in my field used to talk about this, because sometimes we don't have evidence. He said, so I'm going to give you we talk about a randomized controlled trial, right? We have 2 groups that are randomized. One uses this treatment and one doesn't. And you look at the differences between them. But he said, now, are we waiting for a randomized controlled trial before you would use a parachute? Because you're going to wait a long time because no one's going to do the study. But sometimes you have to use common sense and good judgment to understand what you're doing. But you can't do this based on causal inferences. Where you think well, I've given my patient ivermectin, and they appear to get better. So now you go and you tell everyone that, and that's what happened in Long Island. Some well-intentioned general practitioner thought that, I'm sorry, it was actually chloroquine was the drug that he was talking about. And that somehow got to the White House. And you remember someone was spouting how chloroquine was very effective, but it wasn't based on scientific evidence. It was based on someone making an observation. They thought it worked. It was well-intentioned, but it wasn't scientific. So I mentioned the Bradford Hill criteria. So if we're going to make a causal reference, we should look at the experimental design, look at that relative risk. Actually, most statisticians don't even consider relative risk to be significantly important unless it's greater than 2. Now, again, what is the relative we're talking about? We're talking about if you do that mathematics, you have a relative risk of 2. That means there's twice as many people, you know, on let's say on one side of that equation that would be positive. Or it can be, so being exposed to this causes twice as many people in the group who's exposed to have the effect, be it the desired effect or an undesired effect, depending on what you're looking at. And then look for consistency. How many other studies have similar conclusions? And if you get a bunch of studies that are coming to the same conclusion, aha, we're starting to get a little more comfortable here. Is there a gradient, which is very important? So in other words, if this amount of the medication works, but this amount appears to work even better, that also adds a lot of, you know, credence to this conclusion. Is there biologic plausibility? Okay, does it make sense? Is there something happening that's causing a change in the cell that is in effect leading to this protection, let's say? And in the case of vaccine, we're talking about antibody production, or now we can talk about T cells because it takes longer for us to understand the cellular immunity response. Is there specificity? In other words, you're only seeing this effect when the intervention is being done. So the group that is not getting the medication or getting the vaccine, we're not seeing this desired effect. Do we have similar evidence from different sources? Okay. In other words, we can get the same thing occurring in an animal model as we do in a human. Very important. We only see this when the exposure precedes the outcome we're looking at. And that sounds relatively simple, but again, when we're talking about hormone treatments, sometimes people are enrolled in a study and they've been taking hormones. Now you're looking at them while they're being studied, but you didn't bother to include all their experience before. That happens often. And so what they try to do, for instance, in those studies is have what we call a washout period. So they tell the patient, we'll stop your hormones for 3 months, and then you can be included in the study. Big, big flaw. Because the effect of those hormones may be lasting. It doesn't just go away after 3 months, depending on what you're looking at. So let me show you some examples. And this is oral contraceptives and cardiovascular risk. So this is old stuff. So again, looking at these venous clots, venous thromboembolism, you know, phlebitis leads to an embolism in the lung. I have example of cohort studies and case control studies, and it's really, the point I want to point out is that you look all the way to the right, those relative risks are all above 2. So you go, aha, that's important. But look at this one, this is 2.8. So a reporter may say, this was statistically proven to increase the risk 2.8 times more if you took birth control pills. But they didn't bother to look at the confidence interval because that confidence interval in that study crossed 1. It went from 0.8 to 10.5. Huge wide confidence interval, crossed 1. It's not significant and it's vague. So I wouldn't place too much evidence in this, but it does get reported. The one right below it, this one is better. You have tighter confidence intervals and it doesn't cross one. So you're saying, well, this one looks like it does cause blood clots. The other type of experimental model that we talked about, again, case control, and I give you an example of 4 studies, and the one that we tend to like the best are the bottom 2 from the WHO and the quote unquote Lewis paper, because we have a big jump in risk of clot formation, and these numbers don't cross 1 and they're very tight. The first study, the one from the United Kingdom in that group, is just around 2, so it's kind of vague, and it doesn't cross 1. It does cross 1, so it's not statistically significant. What about in past users? Those were current users. So these are women that took it in the past. Are they at risk for clots in the future? And you can see that you simply look at this and you go right to the confidence interval, the 95% CI, and you see that all of these studies cross 1. You can see that the relative risks, except for the one that says 1.28 when they took it for 3 to 6 months, sounds like it's a slight increase in risk, but it's not statistically significant, meaning that point estimate, that estimate is vague, and it could be due to random occurrence. It's not precise. So the conclusions here would be that there's no long-term effect. It's an on-pill effect. What about different hormones? And this became a big war. And it was interesting in that all the newer hormones that were being used seemed to have more of a problem causing VTE. Wow, it's like incredible. Scientifically, we've made new hormonal compounds that appear to be worse. And that's how many of the drug companies were, who had the older formulations, were putting out messages through their public relations people that the newer ones are more dangerous. And yet, when you did the studies, it was all over the place. Some looked better than others. They all hovered around 2. And I think it's now felt fairly confidently that if you, one way you correct for these, you need a bigger study group, because the number of people enrolled in these studies may have been small. So there's a thing called meta-analyses where they take all of the studies, put them in one study, then recalculate the numbers. And often that'll clear up maybe some of this ambiguity. I would say today in 2021, we don't really worry about whether it's a newer hormone or not, because there was a bias here. Remember, we talked about attributable biases, recency of introduction. It just happened like in the United Kingdom, doctors preferentially gave the newer formulations to high-risk patients, thinking they were safer. I'll give you a good example of that. We know that the reason women get blood clots when they're taking birth control pills is estrogen. Oral estrogen of any form gets absorbed through the gastrointestinal tract and goes to the liver. And it's the liver that manufactures proteins that promote clotting. So we're stimulating the production of those proteins. And what they did in this particular study is they looked at the 20 microgram pills compared to the 30 microgram pills. And we know from older studies that the less amount of estrogen, the lower the risk of clot. Well, this all of a sudden was confusing. So if you look at a WHO collaborative study, the relative risk of developing a blood clot taking a lower estrogen dose pill was 38.2. This is enormous. And it was above 1. But look at the confidence interval from 4.5 to 325. This is so vague that it's really, it'll be analogous to trying to throw a stone. If you're trying to hit a coffee cup, that's pretty precise. But if you're throwing it into a lake, you don't have to be very precise. And most people did not particularly accept this study. There were just so many errors associated with it. Studies were published without confidence intervals. So how do you draw conclusions? But they were published. Some journal put it in the, and so this led to a lot of confusion. And I would say today we now know that this doesn't make sense because it's not biologically plausible. So back to our original discussion in that conference room. Who thinks Dr. X had the best support? That she read this review article, which took a lot of review, meaning it took a lot of other scientific studies and led to a larger conclusion. Or Dr. Y, who was citing one study, but it was published in the New England Journal of Medicine that has a good reputation for scientific rigor, so they may have had good reviewers review that study for its appropriateness to be published in the New England Journal of Medicine. Or the professor who's giving his or her opinion. What do you think is the strongest evidence? Dr. X. And I agree. Because even though the Contemporary OBGYN is a review publication, it's not as, scientifically revered as New England Journal of Medicine. That review article had many other studies that led to those conclusions. So it usually would have a stronger strength of evidence than one solitary article. And so often I've seen young doctors and old doctors and in between say, well, and they're citing one scientific article. And then you'll find a year later that article is completely refuted. But that's what the purpose of scientific literature is to put your ideas out, your hypothesis. This is how I prove my hypothesis. And it's the communication device between scientists, communication device between clinicians who are trying to use this information to provide better care for their patients. It's not the best communication for the media, but it's become that. And the media latches onto this because it sells. And I know that in my field, in women's health, women tend to be often the target for a lot of the ways that they deliver news, because women take it real seriously, much more than men do. And women are very powerful in the marketplace. And so if the channel, the news at 10 o'clock wants to attract the female audience, they'll at 8 o'clock, they'll say, tune in at 10 and we'll tell you why taking birth control pills may be lethal to you. You get a lot of women to tune in because they're scared. And they've done this pretty regularly. Or it's the front page of a magazine that's at the checkout stand in the supermarket. They purposely put those type of headlines to get people to buy that magazine to be able to read about it. And you may find it's all filled with errors, but we have no control. And now we have the biggest source of error, uncontrolled source of error in terms of what people are picking up their information, the internet. And believe me, some of my two least favorite colleagues is Dr. Google and Dr. Yahoo. When patients would come in and say, well, I read this. It could be exhausting trying to explain to them why that's not a valid conclusion, but we have no control over it. And guess what? They now have a thing called Twitter MD. Believe me, my blood ran cold when I was told that my residents are using Twitter MD to get their medical information. And they tell me it's legitimate because they do have articles that are published in Twitter MD. But I think, where's the editorial? Who's telling you these are good articles? How well done are they? So it's kind of a scary world that we're in right now because we have so much information and it gets a little bit overwhelming. So I would like to answer any questions that you may have, because I'm sure a lot of this stuff may have been hard to understand for the first foray into it. And I know I didn't appreciate it when I was a medical student, but learned to really appreciate it when I started doing research
Okay. Did you hear the comment from Bob Loom?
for American Scientific
Yeah, he
Association.
rejected almost every submission for 2 years because even the researchers didn't have a clue on how to construct studies or interpret the statistics. You haven't named the greatest confusion, correlation versus causation, nor meta-analysis as a way of combining multiple studies to get better evidence.
I kind of touched on it at the end.
Yeah. And then epidemiological studies, by their very nature, can't have randomized trials because they depend upon large numbers. Those are his comments.
Yeah, so we would not, I would not use the term epidemiological study because in our jargon, those would be observational studies. And so those you can't do randomization in observational studies. Those are cohort or case control studies. So what you try to do is you look after the fact and you try to see whether or not you have a good sample of good distribution. So you may have identified 10 things that you want to look at, and the statistician will look at, for instance, income, education, gender, and you want to make sure that you have in both groups, the group that was given the intervention and the one that wasn't, equal distribution to see if you have a good sample. If you don't have a good sample, you have to keep on recruiting or looking bigger because it's not going to be a valid analysis. Or you're going to write a paper and you're going to explain that we don't really have a representative group. And there's usually people who will then say, so additional studies need to be done. But it's amazing how these things get published. I don't know if you want to be zooming in on individual people, so let's just look at the whole gallery.
Here's the next question or comment from Ron Montaigne. Do you feel the current distrust of science is caused by our political divide supported by biased media sources, or have anti-science politicians just benefited by an America that has grown less educated?
In my opinion, absolutely. Okay, if you look at data and specifically in terms of COVID, I think the Kaiser Family Foundation studies have been eye-opening. And you can see just huge differences based on political party or whether the individuals live in a rural setting versus living in an urban setting. And their decision-making as to, and their beliefs are very much influenced by that. And there is a distrust of science, and the scientists have been demonized. I mean, it's like, poor Anthony Fauci. Do you believe him or you don't believe him? He's a hero to some people. He's a villain to others. And all he's doing, and unfortunately, he got caught in this thing, which I think is very true. What I know today, I'm going to know different tomorrow. I'm going to know different the day after tomorrow. And the American public just doesn't have to understand that. And they're not accepting that. They're thinking, well, they did this study today and now he's backpedaling and he's giving me different information tomorrow. And a lot of the recommendations that were being made in the beginning were in fact not tested, but they were, like an example, wearing masks. It was based on other scientific inquiry that we learned, for instance, when we dealt with infected patients, the people that wore masks when they went into a room where there's respiratory infection didn't catch the infection compared to the people that went into the room that weren't wearing masks. That type of stuff may have been done 50, 60, 70 years ago. And they said, well, let's apply this to COVID. And someone's going to say, no, they never proved it with COVID. And now we know it's true. And I still see articles coming out about the validity of wearing a mask. And yet there's a debate as to whether we should have masks or not. So yes, it's completely influenced by all the wrong influences. But that's our society.
Couple points from Aaron Mosnam. Number of patients participating in the New England Journal of Medicine article. And another comment he made was evaluate professors' credentials and reliability.
Well, again, I think when the evidence-based medicine gurus came up with this list of supporting proof that this evidence is of value, it didn't make any difference what the individual's level of achievement was or how respected they were. It's because it's a single solitary opinion is not scientific evidence. A opinion quoting scientific evidence is a different story. But when people say, well, in my experience, that's, if you have nothing else, that may be helpful, but it really isn't considered to be scientific because no one has enough experience to have seen every, permutation or combination.
I believe the last question. Is there a database or app where one can access the data analyses such as you presented today for the public decisions that are currently being made by the CDC, FDA, and others?
I'm not aware of it. I'm aware of apps from different organizations. I carry some on my phone. For instance, there's one app that I have from the North American Menopause Society because I spent a lot of my career dealing with menopausal medicine that gives a decision support algorithm taking the scientific evidence and looking at the risk benefit ratios for different interventions, different medication, as to whether it's appropriate for an individual patient. So you put in the patient's history and it'll help you come to a conclusion. And there is another app that I used to use from the NIH for the treatment of a bacterial infection in pregnancy, because there were different opinions as to what was the best way of treating it, and it gave you an updated summary as things changed. It would update. There's some new apps that are just coming out now that are really targeted for physicians that would be its decision support. I'm aware of one from AVOMD. I've been looking at this recently, and it does have evidence-based treatment recommendations, and you just put in the disease or the condition, and it'll give you what is considered to be up to date for that particular type of disorder. So they are coming. I mean, I can tell you that AI, artificial intelligence, and algorithmically derived treatment and diagnostic recommendations this is something that's coming to the future very, very rapidly.
Well, that wraps up the chat questions that I can see. So on behalf of all of us, I'd like to say thank you very much for sharing your thoughts and coming here today. And anybody have any additional questions? Well, we look forward to hearing from you in the future, and thank you so much.